So today we'll begin with two short presentations from my colleagues, Dr. Charlotte Hammer and Dr. Freya Jephcott. They will present case studies of their research into surveillance systems and epidemiological obfuscation. After both talks are finished, we will launch into an active discussion and open the floor to questions and comments, as Freya mentioned. So first up is Dr. Charlotte Hammer. Charlotte is an applied infectious diseases epidemiologist who has just joined us here in Cambridge. Her current research focuses on the early detection and prevention of spillover-borne outbreaks of emerging zoonotic diseases. My words are getting mixed up already. So please go ahead, Charlotte, when you are ready.
All right. Yeah, also from me, a very warm welcome to this first session. And let's see. How is this, Liza? Everything as it should be?
Perfect.
All right, wonderful. So I'll be talking about a situation where an epidemic hides another epidemic, and specifically about COVID, so very topical. And this is not necessarily a case where anyone particularly actively hides anything. So these are much more subtle mechanisms that you will see throughout this case study. And obviously, as Liza said, I'm also a public health practitioner, but what I'm presenting here is mostly my own insights and my perceptions. Some of it is sort of systematic data, not all of it is systematic data, so please take that with a pinch of salt. And I'm obviously also just representing myself and not any present of former employers. Now, with that out of the way, this might be quite familiar for a lot of you. This is the original ProMed mail notification for the first cases of what would later become COVID-19. For the non-epidemiologists in the room, ProMed mail is an informal network where infectious disease experts post information about certain events, be that infectious diseases that are cropping up, that are new, anything unexpected. And it is open source, it is open to everyone, so you can go and check it out. And that is what one of those notifications then looks like. And this is the one for COVID-19 for the very first cluster. Oops, sorry, that was the wrong direction. And there you can see this was on the 30th of December 2019, when much of the world was not quite aware of what was going to come yet. A few people in the relevant circles were already discussing the unusual cases of undiagnosed pneumonia at that time, probably since sort of mid, maybe early December. But this was the first time it kind of came to a wider stage. So we're on the second to last day of 2019. Then 5 days later, we get this tweet from the WHO about the report of a cluster of pneumonia in Wuhan, Hubei province. So this was probably one of the first very public declarations of these new cases, and quite little was known at that time. This is another 5 days later. This is the 9th of January now, and this is ECDC. ECDC is the European Center for Disease Control, so it's kind of like the European equivalent to the very famous US CDC, except that it has a lot less staff and it has more of a coordination function, because obviously each European Union country has its own variant of the CDC, just like the UK has what used to be Public Health England and is now UCSA. And on the 9th of January, ECDC published their first threat assessment brief on these new cases with pneumonia of unknown etiology. And they didn't quite know what was going on. Something was going on. This was also the point where a lot of us got quite concerned already. And especially those of us who are a bit older than me, who actually had first-hand experience with SARS, were, as far as I'm aware, very concerned by this point. And then another 4 days later, on the 13th of January, by that time the world kind of knew about COVID-19. And that was the day we all were notified of the first case outside of China, the first case in Thailand with a traveler from Wuhan. And then we're moving further into January. On the 17th of January, we get the first rapid risk assessment from ECDC. And in fact, 3 days after this, on the 20th December, on the 20th January, sorry, ECDC started to publish the sort of daily risk assessments. And in fact, the Epidemic Intelligence Division of ECDC had started in-depth surveillance of these new cases on December 31st, so 1 day after the first case was notified. And then we got the first European cases. First case in Europe was January 24th, a traveler from China in France. Few days later, we had the first case in Germany. Again, traveler from China, but we also had autochthonous transmission in Germany. Autochthonous transmission means that we had actual transmission in country. These were no longer travel associated cases, not all of them. So we had a first cluster. And then I was working in Finland at the time, and we had our very first case on January 29th. That was a traveler again from China who was visiting northern Finland. So also who happened to be in an area with relatively limited resources for a very high resource country. But in fact, it was not long after that that we started sort of our full response in Finland as well. And in fact, I wrote my first briefing, my first morning briefing on COVID-19 for the epidemic intelligence, I believe on February the 9th, but obviously other colleagues did that before me. So we started in late January already to write daily morning briefs on this. And then we had the declaration of a fake, that's a public health emergency of international concern. Sometimes also pronounced a fake, but apparently I've been told fake is the correct pronunciation of the person who coined the name. In late January, we had first reports of limited human-to-human transmission, and then 2 days later, the emergency committee was convened. The emergency committee at the WHO is the committee of experts who advises the Director General whether or not a fake should be declared. At that point, we had just under 8,000 cases worldwide, and only 82 of those were outside of China, but already in 18 different countries. And the day after that, the Director General of the WHO officially declared the fake, which is still ongoing to this day. And then things really started to kick off. So in late February, we had a joint WHO and ECDC mission to Italy because we obviously had this very, very bad situation in northern Italy that I think everyone here still remembers quite vividly. And from then on, it was just COVID, COVID, COVID everywhere, which I think you all can relate to. It's kind of become the topic of our lives, both personally and professionally for some of us. But why am I telling you all of this? I mean, we're talking about hidden epidemics. This does not look hidden, does it? So was COVID a hidden epidemic? I know that there is some discussion regarding that in the early stages. But even, I mean, I'm not going to touch that discussion, but even if it was in the early stages, it didn't remain that for long. So again, why am I talking about this? Because I wanted to show you what kind of resources are already bound with COVID in early 2020. And that begs the question, what on earth happens to all the other diseases while we're busy working on COVID-19? And there is your hidden epidemic. Now, to look at this in more detail, you need to know a little bit about surveillance and the surveillance pyramid. The surveillance pyramid starts with an infection. So an individual gets infected. In most cases, that individual actually has to have an illness. It has to show symptoms, unless you have some kind of mass testing going on, which is not the standard situation. This person then needs to seek healthcare. Which, for example, for a cold, a lot of us won't. The person also needs to be able to access healthcare and to actually go to a doctor's or to a nurse or to some other kind of healthcare provider. There needs to be some kind of specimen taken, and that specimen needs to be tested. We need to actually have a result from that testing, and that result needs to be reported. So far, so good. This is kind of the classical surveillance pyramid. But for someone who works in a public health institute, it goes a little further than that. because after that report back to the physician, we get a notification. Notification means that a disease that is on a specific list of diseases that are under close surveillance, that the lab or the doctor or both, that depends on the country regulation, needs to notify the public health authorities that they have a case. That means that case ends up in the surveillance system. And then there's some kind of analysis going on with the data in the system. A lot of that in high-income countries is these days automated with automatic thresholds, but a lot of it is also being done by hand. So I've done quite a lot of surveillance data analysis by hand as well over the last couple of years. And only with that do you have some kind of action. Unless someone says in a care home, for example, we have a big outbreak, obviously that would go a slightly different way. But if you're looking at sort of the broader scheme, this is how we get to public health action. And that's why in public health practice, we call surveillance data for action. So there's a lot that happens between that first infection and some kind of public health action. Now, what happens with COVID? COVID interrupts this in various ways, or the COVID response, however you want to look at it. In terms of infection, actually, you might get less infection because some of the measures we're implementing are extremely successful also for other diseases. So think about distancing and masks and banning social gatherings work amazingly well against the flu as well, so against influenza. Then if the person has an illness, has symptoms, it helps if that isn't automatically classified as COVID. COVID test taken, COVID test negative, okay, don't have to worry about it anymore. The person then has to seek healthcare. And now we're getting into the very sticky bits, because a lot of people over the last 2 years have been afraid to seek healthcare, even for very worrying situations, even for cancer treatment, because they were worried of catching COVID. On the other hand, if that person decides to seek healthcare, they need to be able to access healthcare. And we do have at all levels an overburdened healthcare system. It might or might not be collapsing. Again, that's not something I'm going to comment on because that's a whole different discussion. But it is burdened to the degree that it is not so easy to get access to healthcare. And you have all kinds of new barriers. You have situations where you have online appointments, which are not accessible to everyone quite so easily. You have situations where in some places you need to take a rapid test before being able to go in person to a physician, which might also not be accessible to everyone. Then when we get to specimen taken and specimen analyzed, the lab system has also been overburdened since the beginning of this pandemic, because all those tests go somewhere, they go to labs, and also those labs can only work at a certain capacity. The same applies for actually getting a result and communicating that result. And again, once the result is communicated, it goes into an overburdened healthcare system. So already this bottom part of the pyramid is incredibly impacted by COVID. And I've just given some examples here. So there are a variety of other ways that COVID is impacting this. Now, if we go into this top part that I added for the public health system, if you go to notification, again, the overburden of the system comes into mind when it comes to things like also notification speed. Legally speaking, there are certain time limits here, things where, for example, in some countries you have 24 hours to notify. But obviously, if a system is overburdened with responding to a pandemic, these are among the first things that go out the window for very understandable reasons. And then at all other levels, we also have an overburdened public health system because people can only work so many hours and on so many things in parallel. And we also have a shift in priorities towards COVID response. So COVID is interrupting the whole surveillance system, basically, and that can hide other epidemics, or at least other outbreaks and disease burdens. So let's look at some examples. These are measles cases in the United States, and this is 2010 to 2020. Don't get distracted by the massive amount of cases in 2019. That was certainly out of the norm as well. We wouldn't have necessarily expected that again in 2020. But if you look at 2020, that is definitely not the figure that was expected. And it's probably not the figure that is real. While some of the measures also massively reduce the burden of measles, it is quite certain that there might have been more cases that just never made it into the surveillance system. Oh, sorry. This is measles now across the entire world by WHO region. Disregard the colors, we're really only interested in the overall figure. So you can see, and hopefully you can actually see my mouse. Here in 2019, you have this massive peak. So the winter peak that's traditional with measles, and you see it in the years before that as well, here and here. And you have that in sort of the winter 2019-2020 as well, but it's much lower. And it also goes down much quicker. So basically when COVID comes up, it goes down to almost zero very quickly. And it doesn't come up again in because in September, October 2020, it should have come up already for the winter peak, and not much happened there. So this is a problem worldwide. And these are just really two examples I'm taking here out of the international measles monitoring. That's Nigeria and DRC, where you can very nicely see how the measles cases go down with COVID going up. And that is definitely, at least to a certain degree, COVID surveillance swallowing up everything else. Now this is something else, this is influenza. And this is in fact only the seasons during COVID. And there's really two things I want you to see here. On the one hand, you see that the numbers are fairly low, unusually so, but they are still there. So there is some surveillance still ongoing. And you can still see that there is a peak in the winter of 2020. So this here is winter 2020. And then there is sort of mixed activity going on throughout the rest of the year, but a lot lower than you would normally expect. And here is something similar for Europe. So this is the 2020-2021 influenza season in the European Union. So this is ECDC data. And you can see that in Europe, we did not necessarily have this winter peak. So in green, you can see sort of the maximum between 2015 and 2020. The red dotted is the minimum, and the purple dashed line is the mean from 2015 to 2020. And with the kind of full red line, you can see that we were below that in the winter peak. We were in fact above it around the peak, but we had a very different dynamic, which is to some degree a surveillance artifact, which is to some degree due to the measures, but you can see that something is going on then, that COVID has an impact here as well. So I've been talking about measles and influenza, but what about RSV? That's a virus that mainly affects little children and can be quite severe. What about mumps, rubella, pertussis, rhinoviruses, other diseases? I mean, rhinoviruses, I don't care so much. They are usually just common cold viruses. They are not so severe, but some others on this list are quite severe. So are we just not able to detect anything anymore? Is that just it? And COVID killed our surveillance? Well, not quite. I mean, you've seen with the influenza that we still can do surveillance and we can still see dynamics, but the levels are lower. But we do have a year and a half now of experience with this, so you can, to a certain degree, also extrapolate by how much they are lower. And we have also been successful in detecting some of those situations where a single case warrants further looks. So those are very severe diseases where a single case, both from a national and public health point of view, requires intervention, but also internationally requires notification through the international health regulations. And one of those examples is actually from last week, because last week we detected an Ebola case in North Kivu in the Democratic Republic of the Congo. And that is a very challenging setting. They have a host of health issues. They have a host of issues related to COVID, and it is also a situation of civil unrest. And it was still possible to detect that case. So a little bit of a hopeful note towards the end of my talk. The question that remains is, what can we do in the future, for future pandemics, for future situations where we have an overwhelming international event that kind of takes away resources. And I'm going to leave you with some questions here. And would any of these suggestions help? Should we try to overcome the human resources bottleneck? So recruit way more people into the healthcare and the public health systems? Should we have surveillance systems that are agnostic to disease diagnosis? So-called syndromic surveillance systems that just record based on syndromes and symptoms rather than on an actual lab confirmed diagnosis. And they are usually much, much better at, for example, picking up unusual events. Should we shift priorities in a pandemic? Shouldn't we shift priorities? Should we shift priorities back again away from COVID? Should we do anything different at all? Or is this maybe just as best as we can do? And I'm not going to give you answers to all of these questions. I have some opinions to some of them, but I don't have definitive answers to all of them. And I'm going to leave you with those questions and invite you to follow us on Twitter and to come to our other talks. Thank you.
Brilliant. Thank you, Charlotte. Some very thought-provoking questions indeed. Do you want to stop your screen share?
Yeah, hang on.
And we can move to the next speaker. So we'll hold off questions until after both talks. So we'll move straight on to Dr. Freya Jephcott. So Freya is a medical anthropologist and field epidemiologist at Cambridge in the CSER department. Her work focuses on the effectiveness of outbreak response systems in resource-limited settings. So please go ahead, Freya.
Thank you. I thought I would take a swing at two short examples of where surveillance systems have kind of ended up doing the opposite to what they're meant to do. They've ended up actually concealing large burdens of disease. The first example is quite a straightforward one. And the only reason I'm really describing it here is because I think it's an interesting example of how obfuscation can be the sum of so many different factors, from material landscapes to just the sort of relative social status of doctors and patients. So this first example, fevers of unknown origin, it comes out of my work on facility-based surveillance systems and under what circumstances facility-based surveillance is likely to pick up a newly emerging infectious disease. So facility-based surveillance is essentially what we rely on to pick up emerging public health threats. I mean, there's a few other sort of augmenting and supplementary surveillance systems, sentinel surveillance systems, wildlife testing, all these kinds of things. But really, we're sort of counting on either a healthcare worker like a doctor or nurse sort of raising a flag when they look around and see a few too many people with this problem, or the routine surveillance data collected by health facilities, which gets fed into the sort of national public health structures that at some point, some tier of these structures, a data analyst or epidemiologist will take a look at the graph and be like, gosh, something's going wrong in that area. We should probably check it out. Pretty much what Charlotte was describing she used to do before coming to Cambridge. So the way that I attacked this question of under what circumstances would facility-based surveillance pick up a newly emerging infectious disease? Well, I used my favorite sort of quasi-anthropological method of stalking sick people. So all of the research I'm going to describe now takes place in Ghana, in particular the Bronga-Hafa region of Ghana, which is pretty much smack in the middle. The way this works is I recruited 12 households in this area that has very large fruit bat colonies known to harbour some quite nasty viral zoonoses. And every time someone in one of these households got sick with a fever, I essentially just followed them throughout the entire illness episode, even if it went for sort of months. And if during that illness episode, they ended up going to a formal healthcare facility, I'd pay a lot of attention to the diagnostic processes, the kind of reporting and recording that went on, and then I would try and trace where that bit of data ended up over the following months. The hope was that by the end, I'd be able to have some sense of how to reconcile the burdens of febrile disease I was seeing in the community with the surveillance data that was getting produced at the regional and national level. So over the course of about 9 months with these 12 households or 80 people, I got about 24 complete illness episodes documented. I think the easiest way to approach the results is if we split it into the first bit being treatment-seeking behaviors. That's under what circumstances would people with fevers in this area go to a formal healthcare facility? And then in the second bit, look at the kind of diagnostic processes in these facilities. So this is a very sort of crude diagram showing the treatment-seeking patterns. Hopefully the first thing you notice is that people living in towns who are a bit wealthier and a bit closer to formal healthcare facilities had slightly different treatment-seeking patterns to people living in the villages. For the purposes of facility-based surveillance and working out when people use it, there were 4 categories of illness that were relevant. The first, which isn't up here, was infectious illness. And for the people in this area, the Bono, infectious illness was anything that gave you a rash, quite a pronounced rash, or a bad cough. And if you developed these things, you were sent like straight to the hospital. People would give you money and you'd go. I think that's probably the result of quite a lot of TB educational campaigning in that area and some kind of living memory of smallpox. The other 3 categories, as you can see, were routine illness, enduring illness, and severe illness. A routine illness was any kind of illness that either didn't interfere with your daily activities like working or going to school, or it did, but it could be resolved locally, you know, a bit of paracetamol or maybe some herbs. An enduring illness did disrupt your daily activities and couldn't be resolved locally. And in those instances, people would initially, you know, give it a go with what they had around the house, but eventually they'd end up going to the hospital. But actually, the townsfolk would go to the clinic first, whereas the villagers who, if they had to save money for transport to a hospital anyway, or a health facility anyway, would just go straight for the hospital. The other difference in this pattern is that whilst the townsfolk had the resources to go to a hospital a few times if the first trip wasn't enough to resolve the illness, the villagers could only afford to do it twice because they were sort of crowdsourcing money for transport. And after about 2 trips, you know, people were a little less ready to give over money for this kind of ineffective process. That said, with the townsfolk, after that 3rd trip, they tended to lose a bit of faith with this biomedical approach anyway, and go look for a spiritualist or go back to the herbs. And finally, in the case of severe illness, everyone just went straight to the hospital. So if it looked to be life-threatening, that's where you'd go. So we can already see under what circumstances, if you've got a fever, you end up in a formal healthcare facility. Now, when you get there, without fail, they'd just see a nurse, the nurse would take their temperature, height, weight, and blood pressure, and then they get sent through to a doctor. And the doctor wouldn't physically examine them, they'd just ask for a list of current symptoms. So it was quite a streamlined process. There was no treatment history collected, they never really read over their medical record. And at the end, the doctor would just hand a prescription to the patient who would go off and buy the drug. The doctor never actually told the diagnosis to the patient. So, like in theory, the way that you'd expect diagnosis to work would be a sort of differential diagnosis. You'd think about all the possible conditions that could cause the patient's symptoms, and then you'd order them in likelihood or perhaps sort of danger, and then work through them. Well, in this area, anyone that presented with a febrile illness was initially treated as a malaria case. If it wasn't malaria, then they tended to be just given a sort of broad spectrum antibiotic. Rarely were diagnostic tests used. The area at the time did have a shortage of a malaria rapid diagnostic test, which could explain some of this. But if you've read Claire Chandler's brilliant work on overdiagnosis of malaria, you'll know that that's not really much. It doesn't change that much having them or not having them. So this differential process started with malaria, then bacterial infection. And really the sort of list of candidate conditions was determined by the availability of treatments and the availability of tests, because you're not really going to bother diagnosing someone with something you can't treat because it's not really a productive interaction. The other issue here, though, as you can probably have already guessed, is that because they weren't taking patient histories and there wasn't much communication between the patients and doctors, there were lots of redundant visits. So actually individual cases ended up getting repeatedly treated for malaria. So on average, you'd have a febrile illness episode, the person would go to the hospital, they get treated for, given antimalarials, go home, it wouldn't work, they'd come back, doctor wouldn't know they'd been there last time, again would give them antimalarials, they'd go home, they wouldn't work. And in the case of the townsfolk, they'd come back and probably at that point tell the doctor and get a broad spectrum antibiotic. Whereas a villager normally after that second visit would just stay home at this point. Obviously here there's an issue that there's not really any feedback loop to tell the doctor that they've made a bad diagnosis or it hasn't worked out. And in fact, there's something worse. So if you follow the data that was generated by these interactions, a single illness episode would end up being recorded in the district surveillance data and then the regional and then the national as multiple individual cases of malaria. And then maybe eventually some kind of bacterial diagnosis like a case of upper respiratory tract infection or cellulitis. The result of this was that the surveillance data then fed back into the doctor's priors that this area has a ton of malaria and it's causing most of the fever cases, which then sort of makes the problem even worse and the likelihood of identifying some kind of novel agent even lower. So I don't think this is going to surprise many people, but my main finding from the body of research this comes from was that the point at which facility-based surveillance picks up a newly emerging infectious disease or some kind of unusual threat is the point at which it runs out of beds or a kind of key treatment. That's really what sends up the flag and not before then, at which point you're kind of out of time for that early intervention. So the reason I thought I'd present this one, even though maybe it's a little dry, is that it just shows the sheer number of factors that can lead into this and the production of these distorting feedback loops. So here we could see that treatment-seeking behaviors were relevant, taxonomies of illness terms, costs of transport, the relative socioeconomic status of doctors and patients, and language and race. The length of illness episodes was really key to how this process worked. Yeah, just gaps in system design, all kind of summing together to determine how that burden of disease in the community eventually did or didn't translate into the surveillance data getting reviewed at the national level. Sorry, it's very weird talking to an audience you can't see. So hopefully this is going well. I'm now going to switch to my second example, which is on the polio surveillance system in Ghana and what it is and isn't catching. So I wasn't feeling very creative this morning, so I've gone with something other than polio. Now, this next case study, why I find it so interesting is that here you can see a really distinct and large burden of disease actually getting picked up by a public health surveillance system and the people who sort of comprise it, the public health workers, but just not registering as there. I'm hoping to actually do more work on this because I'm a little sort of taken with it. Here, the methodology was a bit different. Essentially, it was ethnography. So for about 3 years on and off, I hung out with district disease control officers in this area and followed them whilst they did their jobs. So, relevant background. Acute flaccid paralysis is, or AFP, is when a child under 15 years just spontaneously develops paralysis without sort of any obvious cause, like they didn't fall out of a tree or get hit by a bus or something like that. Now, the reason why people look for acute flaccid paralysis quite so eagerly is that it's a surveillance proxy for polio. And polio is one of these name notifiable diseases under the international health regulations. So countries are obliged to report cases, but also it's been targeted for eradication. So polio surveillance systems tend to be somewhat parallel to your main surveillance systems and your main public health surveillance systems, and they tend to be quite well resourced. I think it's probably worth noting Ghana hasn't had any cases of polio, or at least confirmed ones, since 2009. But this one area of Ghana, every week we would go out for 1 or 2 reports of acute flaccid paralysis. So something was going on. Now, what happens when you get a report of acute flaccid paralysis? Well, normally these are picked up by either community-based surveillance volunteers, so just community members who volunteer to look out for particular diseases, or normally nurses working in clinics. Doctors rarely report these, I think, because they don't put polio in their differentials for paralysis. But when they get reported, it goes to the district health management team. A district health disease control officer goes out, fills out something called a case report form for AFP and grabs a stool sample and then sends a copy of the form and the stool sample into that main public health system, which eventually ends up with a reference laboratory in the capital Accra. Now, as a rule, in the Ghana Health Service, if there's an exciting result from a reference laboratory, they'll call the district officer and let them know. If there's a negative result, they tend to just never mention it. So after about a month or 6 weeks, the district disease control officers would write RO on these forms if they hadn't heard anything, which they never had, for ruled out. And then they'd sort of file them away in this archive where they were definitely there, but completely, you could just never find them again. So present, but in no way retrievable. This is what it looks like. So this is an acute flaccid paralysis case investigation form. You can see that the district officer went out, took the information. You can see the stool specimen results area is blank as they are on all of them. And then the follow-up examination, which took place a few weeks later, it's all there. Sorry, there we go. I hadn't realized it had these fancy graphics on it. Here you can see the stacks of forms waiting on a desk for a call from the lab that never comes. I first found them, I first found these forms when I was doing case finding for a different outbreak of encephalitis in the area. And there were just hundreds and hundreds of them in these archives. And it wasn't just AFP cases with this ruled out scribbled on them. It was yellow fever and measles too, because these are again notifiable diseases that have these quite robust reporting systems. Something I found quite interesting about this is clearly they were regularly going out to deal with children with this unusual form of paralysis. But when I asked people about what would you do if you had to deal with a burden of disease of unknown etiology, of unknown cause, they would be like, oh, that never happens. And I'm like, yesterday we went out to a cluster of 3 cases of children with paralysis that we have no idea what caused it. But then it wasn't quite clicking over. And so I'd keep pushing people to be like, go on, but just if it did happen. And instead you'd end up in these weird sort of hypothetical, forever referring the sample to an ever more sophisticated reference laboratory thing. It's completely distinct from what was actually going on the ground. There's an anthropologist called Claire Wendland that referred to this kind of thing as imagined routines, kind of what we actually do relative to what we think we do as clinicians or public health practitioners. And I think that a lot of epidemiological obfuscation sits in this particular blind spot between what we'd think we'd do in a particular scenario and what we actually do. Now, I know looking at these pictures, immediately it looks like kind of apathy or dysfunction to pile up all these cases like that and forget them. But if you know these district disease control officers, they are anything but apathetic, and they are just incredibly high functioning, like they go above and beyond so often it's ridiculous. So I think actually what's happening here with these forms is this process of maybe fixing and forgetting. Sorry, I'm just getting messages. Of fixing and forgetting. Oh, sorry, slide issues. Where essentially the forms being used to give a physical, a sort of material form to this ambiguous event, which allows them to triage it. They can sit it on their desk for a few weeks, and then either someone calls saying they're polio and they can dive to action, or perhaps more cases come in to the point where the scales tip and suddenly there's recognition there's an event that needs some kind of ad hoc response. Or nothing happens, and at that point you've got this aberrant event that doesn't quite fit within the system at all. It's not easily accommodated, but you can kind of make it disappear without doing anything deviant by filing it in this way. So I think there's something going on there. Like I said, I'd like to dig into this a little more with future research, but I'm excited to hear your sort of takes on this in the discussion. Like so much of what I do in anthropology, I think I've discovered something really interesting, and then I speak to often a vet who then describes exactly what I've seen, like everybody knows it, and it's always been that way. So here's a quote from one of the vets in the area when I was asking him what he does when he gets outbreaks of unknown etiology in animals. And he said, it's chaotic. There isn't such a system in place. These things are not going far. If a vet finds an outbreak of something unfamiliar, he makes his best guess and informs his superior, and then he lets it go. With a Ghana Health Service person, it will just get buried in their files and that's the end of it. So I think people were generally kind of aware of this system of handling outbreaks of unknown etiology, even if they weren't sort of consciously aware that that was their system of handling these kind of slow burn outbreaks of unknown etiology. This is from some of the heads of the National Surveillance Unit in Accra. And I think this maybe sums it up. The truth is, if there are not deaths and it's not causing anxiety and the media doesn't know, then it just goes off the radar. Or some way, somehow, these things fizzle out. It died a natural death. That was in response to an outbreak that got initially investigated, but the investigations didn't go anywhere, so everyone just sort of lost interest. Now, the final interesting thing about this acute flaccid paralysis burden of disease in the Brong-Ahafo is it's not just these district officers who are sort of interacting with it, where it's getting picked up but not quite registered. Every year in the Ghana Health Service's annual health report, if you flip to the polio section, so the acute flaccid paralysis performance indicators, you'll see that the Brong-Ahafo region reports 5 times the incidence of acute flaccid paralysis of the rest of the country. So as you can see here, that red area is the Brong-Ahafo region, and Techiman's kind of in the center of that cluster. That area Techiman has a population of 150,000 people, whereas Accra, that other big cluster in the south, that has a population of 2.5 million. They shouldn't look that similar in terms of the number of dots. And this is year on year. Every year, because of the population size, they expect about 20 cases of acute flaccid paralysis. And every year it reports about 100. So there is, it might be a mixed bag of different agents and etiologies, but there's something happening in this area. And people at the district level are interacting with it. People in the national level have it in their charts and graphs in the polio section, but it never quite gets registered as a distinct and actionable burden of disease. And I think there's something quite interesting there. So I thought a point of discussion from this one might be just what is this failure to recognize these cases? Is it just habitual practice, or where does this blind spot come from? All right, I'll hand back over to Liza. That's me done.
Brilliant, thank you, Freya. Really interesting.